Dr. Anita Saxena. Additional Professor, Department of Nephrology, several clinical trials on immunosuppression, diabetes, nephrology, hyperphosphatemia, renal nutrition. She has published 4 books, 2 on renal nutrition, 1 on protocols in nephrology, medical genetics, and she has 45 publications to her credit. She started Journal of Renal Nutrition and Metabolism and started Society of Renal Nutrition and Metabolism, and she has won many internal and national awards.
Thank you, Chairpersons, and good afternoon, ladies and gentlemen. Let me at the very outset thank Dr. Ckd Agarwal for having invited me here for this CME. And in fact, it's the last lecture of the day. I won't be taking very long. I'm going to speak on pathophysiology of protein energy racing and nutritional management in CKD. But before I get on to the topic, I'd like to inform you that from where do you have this? Yeah, so I'd like to inform you that we started a Society of Renal Nutrition and Metabolism in the year 2014, and the aim of this society is to prevent malnutrition amongst CKD patients. And in order to realize this goal, we need to join hands with you, and that is the main reason I'm here, and I'm really thankful to Dr. Agarwal for this. Before I get on to the talk, I'd just like to know how much awareness is there about the renal nutrition. So I'm going to ask 4 general questions to the audience about renal nutrition, and for every correct answer, I'll be giving you a prize. So my first question to you is, let's check up. Who's looking after this? Yeah. What are the 2 most common features of renal disease? Is it fever, decrease in GFR, proteinuria, hematuria, and malnutrition? What are the 2 most common features of renal disease? Can you please answer, anyone? Okay, fine. So the correct answer is decrease in GFR and malnutrition. So you get a prize. Would you please be kind enough to... Wow, congratulations. Now, my second question to you is, what is low protein diet according to international guidelines? Is it 0 or no protein intake? Is it 1.2 grams per kg body weight per day of protein? Or is it 1.5 grams per kg body weight per day of protein? Or is it 0.6 grams per kg body weight per day of protein? You are the one. So I think the correct answer is 0.6 grams per kg. So the gentleman with the striped shirt. Congratulations. Now my third question to you is, which of the following foods are of high biological value? Because it's very important for CKD patients. Are these leafy vegetables, tomato, milk and milk products, eggs, fish, chicken, or soya protein?
Egg, fish, 4 and 5.
4 and 5. Who else? Anyone else? Anyone else? Soya protein. Good. So, who is saying all the 3? Okay. Well, the correct answer is milk and milk products, eggs, fish, chicken, and soy protein, because we're going to talk about it. We want to give high biological value protein to the patient. So, does anyone get the prize? No. He said 2 of them, the one in the blue. He said 2, so you can give him the prize. Okay. So my last question to you is, how much protein does a patient with diabetic nephropathy require? Is it 1.2 grams per kg body weight per day? Is it 1.5? Is it 0.8 grams? Is it 0.6 grams per kg? Or is it 0.8 grams per kg to be reduced to 0.6 grams per kg as GFR declines?
5.
Okay, who said 5 first? And so you get the price. The answer is 0.8 grams per kg body weight per day, and as GFR declines, it should be reduced to 0.6 grams. So congratulations, and I'll start on with my talk. Now we all know we've been talking about chronic kidney disease since morning. Chronic kidney disease is a major contributor to the global burden of non-communicable diseases. The three principal outcomes of CKD, which was my first question, are progressive loss of renal function, development and progression of cardiovascular disease, and development of malnutrition. The prevalence of CKD is reported to be 17.2% according to the SEEK data, which is the latest information. And three most widely studied interventions, that is the modifiable characteristics linked in their effect on GFR, are lowering of blood pressure, proteinuria reduction, and antihypertensive medication. And other factors instrumental in slowing progression of CKD are strict glycemic control, lipid-lowering therapy, smoking cessation, dietary modifications in terms of protein and salt restriction, and regular exercise and weight reduction. Now, in CKD, the term malnutrition has been recoined as protein energy wasting, which simply means loss of body protein mass and fuel reserves. Now, according to the Ckd Registry of India, with increasing CKD stage, the BMI decreases. As you can see, that at stage 1, when the GFR is more than 90, the BMI is high, and as the stage is increasing and the GFR is declining, the BMI is going down by stage 5. Therefore, protein energy wasting is a major challenge, which leads to poor quality of life, and is one of the strongest predictors of mortality in patients with CKD. Now, what causes decreased protein and energy intake and hence malnutrition in CKD patients? It is simple, it's uremia. Uremia is the main culprit, which eventually leads to malnutrition. What happens is there is, because of uremia, imbalance in hormones like leptin and ghrelin, which leads to anorexia, loss of appetite, hunger, decreased hunger and calorie intake, and eventually, as the disease progresses, the resting energy expenditure increases from 12 to 20%. Along with this, as the stage advances, there's retention of middle molecules and urinary compounds, and metabolic acidosis causes accelerated protein catabolism, leading to loss of lean body mass and increased mortality and morbidity. And when all this is happening, there is secret thing happening, that is inflammation, which cannot be seen with eyes, but it is there, which causes increase in acute phase reactive protein, which leads to reduced protein synthesis in the liver, leading to hypoalbuminemia, eventually volume expansion, and along with this scenario, intercurrent illness gives rise to systemic inflammatory response syndrome. So once chronic kidney disease sets in, the vicious cycle of anorexia, malnutrition, inflammation deteriorates nutritional status and affects quality of life and survival. So therefore, nutritional management in kidney disease is focused on prevention of progression of kidney disease and malnutrition. Now, management of disease depends on the stage of the kidney disease. With advancing stage, nutritional management becomes more and more intense. So now, why do we need to modify diets? Well, it's been shown that the medical nutritional therapy allows a good control of several consequences of disease like nausea, vomiting, anorexia, and can also delay initiation of dialysis. Now, low-protein diet has been shown to have independent therapeutic effect. We know that dietary protein causes postprandial hyperfiltration, induces or increases proteinuria, leads to glomerulosclerosis and renal insufficiency. Now, low-protein diet has been shown to have anti-fibrotic effect, and low-protein intake therefore lowers hyperfiltration, retards onset of proteinuria, and glomerulofibrosis. Even the source of protein has independent therapeutic effect, whether it's from the animal source or it's from the plant source. Plant protein should be preferred over animal protein because there's 20% less proteinuria in soy-based diet, that is the plant protein, and fibrosis has been shown to be lowest in soy groups compared to the casein, which is the animal protein. Therefore, reduced animal protein intake would reduce glomerular hypertension. Now, we know that ACE inhibitors and ARBs reduce degree of proteinuria in renal disease, and when low-protein diet is combined with ACE inhibitors and ARBs, there is additional anti-proteinuric effect which is observed. The enalapril trial, which of course we are all aware of, has shown that if enalapril is given 20 milligrams per day, it reduces proteinuria by 20%, but if it is combined with low protein diet, the decrease in proteinuria is by 30%, which is remarkable. So what are the markers of protein energy malnutrition in our patients? It's basically progressive loss of weight, wasting of fat and skeletal muscle tissues, and reduction of serum protein. Now, there are certain important independent nutritional risk factors for mortality in renal patients which reflect malnutrition, like low serum albumin, which is less than 3.8 grams per deciliter, low HG scores, low normalized protein intake, and low BMI, which is less than 23 kilograms per meter square. The MDRD study has shown that as GFR declines below 60 ml per minute, there is a spontaneous decline in protein and energy intake, and also a decline in serum albumin levels. So the first thing that we need to do when we have a patient with chronic kidney disease is to screen him whether he already has malnutrition or is at a risk of developing malnutrition. We do not know how well he's been eating. So the simplest option for screening tool which is available to us is called malnutrition screening tool, which simply asks two questions. Question one is, have you lost weight recently without trying? If the answer is no, the score is 0, but if the answer is unsure, the score is 2. Now the second question that you ask is, have you been eating poorly because of decreased appetite? If the answer is no, the score is 0, but if the answer is is unsure, the score is 2. And if your score is 2, then the patient has already developed protein energy malnutrition. So this is something when the patient comes to you, you can always observe. These two simple questions will direct you how to go for nutrition assessment and the therapy. Now, International Society of Renal Nutrition and Metabolism has proposed a criteria for diagnosing protein energy wasting in CKD patients, and this has 4 aspects. One is the clinical chemistry, body mass index, muscle mass, and dietary intake. Out of these 4, if 3 are positive, then the patient has protein energy wasting, and out of these 3, at least 1 point should be positive in order to diagnose him as malnourished. So serum chemistry includes serum albumin less than 3.8 grams per deciliter, serum pre-albumin less than 30 milligrams per deciliter, and serum cholesterol less than 100 milligrams per deciliter. Body mass index, as I said, if it is less than 23, or unintentional weight loss over 3 months, that is 5% in 3 months or 10% in 6 months, or there is muscle loss of 5% in 3 months or 10% in 6 months, or there is reduced mid-upper arm muscle circumference, this is a true indicator of malnutrition, chronic malnutrition. This gets affected provided the patient is not having edema. That is an important thing to observe. That's why anthropometry becomes slightly unreliable in patients with CKD, those who have edema. And the dietary intake, if the patient is on dialysis and has been taking less than 0.8 grams per kg body weight per day of protein for at least 2 months, or if he's pre-dialysis and he has been taking less of protein, that is less than 0.6 grams per kg body weight per day for at least 2 months, then he definitely has protein energy wasting. Or if his energy intake is less than 25 kilocalories for at least 2 months, then definitely the patient has malnutrition. Now, what is the relationship between muscle wasting, hypoxia, and appetite? What happens is malnutrition induces muscle wasting and causes cardiac ataxia, leading to left ventricular hypertrophy, which leads to cardiac hypoxia, reduced renal blood flow, which causes gut hypoxia, and eventually anorexia. So remember, if our patient is anemic, he is definitely going to have a poor appetite. Now, this anorexia is again going to do what? It's going to cause gastroparesis and impaired intestinal motility. So it's very, very important to correct anemia in our patients with folic acid, B12, vitamin, and ESAs. We've done a prospective cross-sectional study on our CKD patients. And this was the first visit of the patient to a nephrologist in our OPD, and we found that the patients, even in CKD stage 3, you concentrate on the blue bar, have very low energy intake. That energy intake is less than 50%. And when we grouped these patients based on appetite, whether they were eating well or not, we found that patients, the blue bars, please mark the blue bars, we found that even patients with normal appetite had lower energy intake compared to, compared to what a healthy person would have. So a patient who even tells you that I have a normal appetite, he is still having a low energy intake. And as we saw that as appetite worsened, the energy and the protein intake really went low. And another surprising thing that we found, the relationship between malnutrition and hypoxia and anemia, we found that patients who had who had anemia and who had a worsening anemia, the appetite was worsening. So that's the reason I said we must correct anemia in these patients with folic acid, B12, iron, and ESA. Now coming on to specific nutritional requirements of CKD patients, when the patient is having GFR more than 90 ml per minute, or he's in CKD stage 1, we really don't say anything to the patient, let the patient eat whatever he likes. But if the patient is in stage 2 to 5, then we need to have conservative management of the patient with low protein diet, as low protein diet would improve uremic symptoms and slow progression of renal disease. But in these patients, one must remember to give lot of energy, because otherwise protein will not be utilized properly for its anabolism. It will be directed towards energy utilization. So the requirement in these patients is low protein, that is 0.6 grams per kg body weight per day. And those who are unable to cope with such a low protein, you can increase protein to 0.7 grams per kg body weight per day every day. And 50% of this protein must come from high biological value, as I asked you the question. So milk and milk products, I'll just show you some of the examples. And all these recommendations for prescribing of energy and protein should be based on ideal body weight. If the patient is edematous, we must take into consideration how much edema is he having, so we must subtract that much of weight from the patient's body weight. Then in case of nephrotic syndrome, it's important to mention here, we do give them, the adults, 0.8 grams per kg body weight per day of protein, but along with that, we must also include 1 gram for each gram of protein lost in the urine. So for a nephrotic syndrome patient, the prescription would be, depending upon the CKD stage, whether he's in advanced stage or he's in CKD stage 3, you would prescribe 0.6 grams per kg body weight per day of protein, along with 1 gram for each gram of protein lost in the urine. And also for these patients, plant-based proteins are much better because they are high in branching amino acids. Soy proteins are really good. And we will have to restrict fluid according to the presence of edema. And if the patient is ill, a CKD patient pre-dialysis, he is ill, then protein intake should be increased to 1 gram per kg body weight per day. Then we will not stick to 0.6 grams per kg body weight per day. And energy intake would depend on whether the patient is diabetic or he's above the age of 60. If a patient is diabetic, then for weight management, you have to keep down calories to 30 kilograms per kg body weight per day. But if a patient is not diabetic and he's above the age of 60, we would still keep the calories down to 30 because these patients happen to be sedentary. If a patient is less than 60 years of age, then the calorie intake would be 35 kilocalories per kg body weight per day. And sodium, we've just been hearing about hypertension and other things. Sodium restriction is important because most of our patients have edema and they also have hypertension. So we have to restrict sodium to less than 2.4 grams per day. And if it is malignant hypertension, it is uncontrolled, then to bring it down to 1.5 grams per day sodium. And potassium should be less than 1 milliequal per kg body weight per day. Now, in case of diabetic nephropathy, we already answered the question that protein intake should be 0.8 grams per kg body weight per day, but as GFR decreases, it should be brought down to 0.6 grams per kg body weight per day, and the target glycosylated hemoglobin should be less than 7% according to the latest guidelines. And ADA recommends use of at least 14 grams per 1,000 kilocalories of fiber for keeping a good lipid profile. However, fiber intake can be increased from 20 to 35 grams depending upon the requirement of the patient. The main goal of the medical nutritional therapy in diabetics is to control hyperglycemia, manage weight. Blood pressure should be between 125 and 80, and we have to control hyperlipidemia and bring down proteinuria to less than 1 gram per deciliter. So these are the foods of high biological value, the milk products, paneer, cheese and yogurt, then poultry, and soya products. But we do prefer giving our patients vegetarian meal. So soya proteins are very, very good for these patients. Now, what exactly is the diet that your dietitian is going to give to your patients? And to me, what I feel is the physician should be able to prescribe the diet himself to the patient. He'll feel rather more satisfied. And the dietitian can, of course, look after whether the patient is maintaining the diet that has been advised or not. So if your patient is weighing 50 kgs and you're going to prescribe 0.6 grams per kg body weight per day of protein, then your patient requires 30 grams of protein. So in this 30 grams, what all you can give milk 150 ml, you can give a bowl of dal, you can give curd 100 grams, you can give 1 egg white to the patient, or if he's a diabetic, you can exchange it with chana, that is 25 grams. You can give chapatis, at least 8 chapatis a day, rice 50 grams, and if the patient likes more of chapatis, you can exchange rice with this, or he can exchange rice with other things like fish. If he likes to have fish, sometimes you can give fish also. So my message here is, do not stop protein completely if a patient comes to you with CKD. You must give them a minimum amount of protein which will maintain their muscles. Now, in order to prevent hyperkalemia, which is an important complication of CKD patients because of low urine output and use of ACE and ARBs, we should prescribe them fruits which are low in potassium, like apple, banana, guava, pear, and papaya. And if serum potassium is more than 5, then we have to stop fruits in any case. And also advise the patients to remove or leach potassium from the vegetables by soaking chopped vegetables in lukewarm water for at least half an hour. And patients must avoid green leafy vegetables, tomatoes, sweet lime, lemon, orange, carrots, raw salad, mango, dry fruits, fruit juices, vegetable soups, because these are concentrated in potassium, coconut water, melons, and watermelon. So these things must be avoided, no matter what. But if in case the patient is becoming hypokalemic, then you can actually advise them to take juice for that matter. Now salt, we've already spoken about salt. The JNC recommends modification of lifestyle of at least 40 minutes exercise or walk 5 days a week, and dietary intervention that would actually bring down the blood pressure. Sodium restriction is important, we've already spoken about it, and the patient must reduce intake of salty processed food. So patient must avoid canned foods, fruits, pickles, fruit jams, because these contain salt as preservative, and reduce salty processed food like cheese and meat. So the best measure for your patient, if you want to prescribe him 2.4 grams of sodium, is to tell him to take 1 level teaspoon of salt. 1 level teaspoon of salt is 5 grams of sodium chloride, so the patient will get 2.4, 2.5 grams of sodium. So that is the best, simplest way of explaining to your patient. Now, hyperphosphatemia is yet another important complication in our patients. We know that high serum phosphorus concentrations are associated with vascular calcification and high mortality. So, and also, what is important here is to remember that PTH levels start rising when GFR falls below 60 ml per minute, even when the serum phosphorus levels are normal. So even if serum phosphorus levels are normal, it doesn't mean that the patient is not having hyperphosphatemia. It is SGF23 and clotho which are at work right now, but they do require dietary restrictions. So I would say that plasma level of PTH are a better marker of when to begin dietary phosphate restriction than serum phosphorus or serum calcium or creatinine levels. And prescribe non-calcium based phosphate binders to prevent soft tissue calcification, and calcium should be restricted to dietary or supplementation should be restricted to less than 2 grams per day. And if the patient is on vitamin D analogs, then calcium intake should not exceed 1200 milligrams in any case. Now, this is good news for the patients that egg white is an unusually rich source of high biological value with one of the lowest phosphorus to protein ratios, and is also devoid of cholesterol. So you can safely prescribe egg white to your patients, those who are non-vegetarian. And the patients must avoid foods with phosphorus-based additives like cola beverages, enhanced or sauteed meats, frozen meals, cereals, snack bars, processed or spreadable cheese, instant products, and refrigerated bakery products and dry fruits. Now, moving on from low protein diet, that is 0.6 grams per kg body weight, to a very low protein diet, that is a very, very low protein diet, which normally our patients are taking when they come to us. They're not taking dal, they're not taking milk products, they're not taking anything. They're just taking dal ka pani, that's all they come and say. So that is really not very good. But if a very low protein diet is combined with keto analogs, which are the tablets of essential amino acids with a knocked out nitrogen, then it is very easy for them to maintain their nutrition status. The study, modification of diet in renal disease, that is the MDRD study, has shown combination of keto analogs with very low protein diet, that is 0.3 grams per kg body weight per day, can, in pre-dialysis stage, can reduce uremic symptoms, reduce proteinuria, preserve residual renal function, slow down rate of progression of disease, delay onset of dialysis, improve metabolic complications, and preserve nutritional status. But they happen to be a little expensive, so one has to think whether the patient can afford them or not. So here are the results of various studies which have shown that a combined therapy of keto analogs and very low protein diet reduces proteinuria, reduces metabolic, corrects metabolic acidosis, reduces triglycerides and also phosphates in the body. Now, we also did, we recently published this data in a journal on a randomized clinical study on the effect of alpha-ketanols in retarding progression of chronic kidney disease. We supplemented our patients with 0.4 grams per kg body weight per day of protein along with 6 tablets of keto analogs. And we supplemented them for 10 months, and we found that in the keto analog group, the results were very encouraging. The albumin was maintained at 4, while the albumin in the controls dipped down from 3.8 to 3.9 to 3.0, which is malnutrition. Creatinine came down from 1.6 to 1.4 in our supplemented group, while it increased in the control group from 2.2 to 2.4. The GFR was maintained at 47 ml per minute in the keto analog group, while it declined by 14 ml from 51 ml per minute to 37 ml per minute in the control group. So which means that the data is encouraging, and if patients can afford, we should think of supplementing them keto analogs in order to retard progression of renal disease. Now, what kind of a diet would you prescribe if you want to give 0.4 grams per kg body weight per day of protein? The same, 50 kg person, if you're giving 0.6 grams, you give 30 grams of protein. But if your patient, you want to give 0.4 grams per kg body weight per day of protein, you bring it down to 20 grams. But remember to give him high energy intake, very high energy intake. And in this diet, you can always give milk 125 ml, dal 1 bowl, and chapati 7 to 8, and he can exchange rice with chapatis and have more of chapatis or more of rice as he likes. So the total protein that he'll get will be 20 grams. And sabudana is a very, or chapoi kasabu as we call it, is very rich in energy. It can give 350 kilocalories to the patient if he takes about 100 grams of sabudana. So you can think of prescribing that for energy, and the rest your dietitian can calculate what ought to be given. Now, the last word about management of patients on maintenance dialysis. I'm sure some of you must be having patients on dialysis also. So, you know that if malnutrition is present at initiation of dialysis, it is a very strong predictor of relative risk of death. This study by Chung et al. Has shown that the patient survival rate is significantly lower in malnourished patients compared to the well-nourished or normal healthy patients. So in hemodialysis, what you do is you just double the amount of protein that you're giving to the patient. 0.6 grams was pre-dialysis, 1.2 grams is hemodialysis, okay? So it's just the double amount of protein that you give to your patient. If your patient is on peritoneal dialysis, then you may increase it to 1.3, but if the patient is clinically stable, then 1.2 grams will be sufficient. But if the patient is having peritonitis, that is equivalent to having AKI, acute kidney injury, you would have to increase protein intake to 1.5 grams per kg body weight per day. Important for dialysis patients that you must supplement them with water-soluble vitamins because they get dialyzed during dialysis. And also zinc supplementation is very, very important to improve anorexia. Anemia, as I said, we have to definitely correct so that they have a better diet and better appetite. But dietary correction of anemia is not possible in CKD. And in order to bring down protein catabolism, we must supplement them with soda bicarb in order to correct metabolic acidosis, and we must try and maintain serum bicarb at more than 22 mmol per liter. As you can see in this study, patients who were supplemented with soda bicarb, they had better nutritional status compared to those who were controls. And also, following this, we must prevent and treat hypoalbuminemia, use appetite stimulants to improve dietary intake, supplement zinc, as I've been mentioning even earlier. Pro-motility agents can be given to the patients to improve gastroparesis. We must treat gastroparesis, do not ignore this. Then anti-inflammatory omega-3 fatty acids and antioxidant agents are useful in these patients, unlike in pregnancy and in chronic kidney disease and AKI. So these are very important, and let me remind you that Indian food is very, very scientific. We know that turmeric all over internationally is known to be an antioxidant and anti-inflammatory. So you must advise your patient to take at least half teaspoon of healthy turmeric every day, either with milk or with water. And garlic, we know, slows development of atherosclerosis and reduces blood pressure. So you must promote garlic to your patients. This is very, very, it's not harmful at all. It's going to benefit the patients a lot. And in order to increase protein energy intake of the dialysis patients, you must give them oral renal specific nutrition supplements between the meals. Do not replace these ONS with the meals. They should be given in between the meals during the tea time. We did a multi-center randomized controlled trial on effect of ONS on hypoalbuminemic dialysis population, and we found, just watch these red bars, we found that the energy and the protein intake went up in the supplemented group. The serum albumin went up in the supplemented group, and there was an excellent effect on the body composition, that all the skin folds, they increased in our patients, though the edema came down. So the take-home message of my talk is prevent, monitor and treat complications in CKD, which cause protein energy wasting, prevent volume depletion in patients who are not on dialysis, and correct uremia and metabolic acidosis to prevent protein catabolism, treat comorbid conditions and infections, treat gastroparesis, advise medium chain triglycerides to patients who have gastroparesis, eliminate drugs which cause GI upset and anorexia, like phosphate binders, calcium supplements, and iron. One can always discontinue them for, say, a week or 10 days and see if the patient is resuming appetite or not. And also monitor closely nutritional status and nutrient intake of the patient, that your dietitian can help you do that. Individualized diet prescriptions. Do not generalize that, yeah, this is the global blanket statement for every patient is different, and every patient's requirement in cultural fats are different, and personal likings are different, so they have to be individualized. And do not completely stop protein intake, and 50% of protein that you give to your patient should be of high biological value. And thank you for your attention. And this is the diet plan for patients who are on HD or PD, 1.2 grams per kg body weight per day. You can safely give your patients more than 1500 kilocalories of energy, 60 milliequal of potassium. Phosphorus will be between 860 to 1000 milligrams, and protein intake will be 64 grams. Thank you for your patience.
Thanks a lot, Dr. Anita. It was a very excellent and informative talk, and it will really help us to counsel better. Now I open the session for any queries. No questions? Ma'am, I would like to clear this doubt about soya-based diet, because what are the food items that we can include? The soya milk and nuggets and what else? Because they're all high in potassium also, I think. No, so what should we do?
Tofu is one which you can give to your patients. Remember, the advantage of plant-based protein is it is not, the phosphates are not absorbed completely. only 50 to 60% of the phosphates will be absorbed. And soya bean is a product which has to be cooked for over a long period of time. If your dal gets cooked in 20 minutes, you have to cook soybean for 40 minutes because you have to break that trypsin inhibitor in that, right? So anyways, you're going to destroy the phosphates in soybean, and on top of that, only 50 to 60% of it will get absorbed. So prefer soybean products to your patients. And animal protein contains organic phosphorus, which is the absorption of which is about 80 to 85%. So that is the reason we are always trying to discourage patients not to take meat.
So can we prescribe the same quantity as pulses, the usual pulse? Okay.
See, if your patient is on dialysis and you want to give 100 grams of soy protein to your patient, you know what is the difference between a milk paneer and a soya paneer? Soya paneer gives you 43 grams of protein per 100 grams. Milk paneer gives you only 13 grams of protein per 100 grams. So you give a larger volume of protein in a smaller amount. Yeah?
And half the quantity has to be prescribed.
Yeah.
Ma'am, what's the role of barley? Jaw का बहुत अच्छा रोल माना गया है इसमें किडनी डिजीज role of barley.
Yeah. We are actually not encouraging patients to take any kind of see whatever we are giving. For example, even dals, we tell them to take dehusked dals because the outer covering of the dal contains phosphates. It is the rich source of phosphates. So we tell our patients bagair chilka ki dal, right? And even with whatever you are asking, if you have to give a refined atta of that. You can't give even for a normal chapati, they are told to remove choker. So we are not very sure how good it is for our patients, but yes, we do allow the children to take this.
Thank you.
Dr. Anita, what about salt intake? हम लोग option patients बताते हैं कि काला नमक या सेंधा नमक
that is such a big problem. Tata has come up with light salt and just tell them to take normal Tata salt because these are high in potassium. We can't give these things to our patients. They will end up with hyperkalemia.
What about this kala namak and seendha namak?
No, seendha namak and normal salt are the same. There is no difference in the potassium concentration. That we've already checked. We got it checked in the SGPGI lab long time back. So that is the same. But kala namak, I'm not sure. So just do. I mean, if they want a little pinch of it once in a while, that they can go ahead with it. But otherwise, just tell them to take normal Tata salt and not to go for some kind of a low potassium, low sodium salt that would have a higher potassium level. Is that all? Thank you.
Now I request Dr. Mukta to please give a moment to Dr. Anita.
Doctor, madam.
I request Dr. Shah sir to please give a vote of.
At the fag end of the scientific session, you are left with nobody. The same is over here. But in any case, I have to fulfill my job. I have to do my job. I am extremely thankful to all the eminent speakers. Those have come all the way from distant places like Lucknow and Delhi, and especially to Dr. Anita and Dr. Anupama. Those have come on a very short notice. In fact, Dr. Anupama has another important meeting yesterday, and on my humble request, she considered to that. And I am really, really thankful to you, ma'am, both of you. You have come all the way from Lucknow on your Sundays. And I am extremely thankful to all the delegates, especially those who have come from outside station or nearby stations. They have closed their clinics, their nursing homes, and so many important jobs for this meeting, because without participation of delegates or speakers, there is no point in organizing a meeting. And my special thanks to all the pharma companies. Those have contributed significantly, and without their contribution and their physical support, this meeting would have not been possible. And my special thanks to my all nephrology colleagues, those have worked tirelessly to make it a success. And in the end, my very special thanks to my wife, Dr. Saxena, who has really worked hard for last almost 15 days, tirelessly. And Dr. Sachin, Well, both of them have really worked hard, and in the end, my special thanks to all my hospital co-workers like Vikas, Verma, and Praveen. Those have worked for almost 30-40 days. Every day in the night, they had a special task to contact people, to do all these paperwork. So with these remarks, I again thank you all for joining us, and now I'll request you all to join us for the tea. Thank you.
Thank you for all. Such excellent meeting.